Ladies and gentlemen, dear colleagues, let us continue with the second part of today's meeting, which is a ceremonial part. First, allow me to say that I have a great honor and pleasure to welcome Professor Tatjana Pekmezovic, the Vice Dean of the Belgrade Medical Faculty, who was so kind to join us here today in order for us to proceed with the inauguration of Professor Jakob to visiting professor of Belgrade Medical Faculty. The motion for this inauguration was made by Professor Lazar Davidovic, the head of the Clinic for Vascular Endovascular Surgery of the Clinical Center of Serbia. It was supported by our society, the Society for Cardiovascular Surgery of Serbia, and at the end, the Council of the Medical Faculty accepted this motion. At this point, I would like Professor Davidovic to introduce to us some most important facts of a very, very rich CV of Professor Jakobs.
Thanks so much, Dusan. This is not mistake. Namely, this photograph is not mistake. Professor Roberto Chiesa is already visiting professor of our medical faculty. Namely, he was elected in 2013, and after his election, he came to Serbia many times. He visited Belgrade many times. He had many important lectures. As you can see, Professor Pekmezovic, visiting professors of Belgrade Medical Faculty proposed by Serbian vascular and cardiac surgeons, come to Belgrade again and again. Moreover, one of the youngest specialists, Dr. Ivan Tomic, had an opportunity to be educated in Professor Chiesa famous hospital. Due to this, we could say that a title of visiting professor of Belgrade Medical Faculty is not only honor from Professor Chiesa, that is also obligation. Roberto, thank you so much. And now I have really special honor and privilege to introduce briefly our another distinguished guest, that is Professor Heinz Jakob. Ladies and gentlemen, it is absolutely impossible to mention all the significant achievements Professor Jakobs accomplished in a such short time. Due to this, I decided to mention the following. After graduation, Dr. Jakob had specialization in general and cardiovascular surgery in Munich, Chicago, Basel, and Mainz. In 1887, he received a certification from the German Board for Thoracic and Cardiovascular Surgery. Currently, Dr. Jakob is head of the Department of Thoracic and Cardiovascular Surgery in West German Heart and Vascular Center Essen, as well as he is professor of cardiac surgery in University Duisburg, Essen. Until now, he published almost 400 original articles, as well as 27 books or book chapters. His citation index is over 8,000, while his H index is almost 50. Until now, he had more than 200 invited lectures. He is included in many well-known research project studies, trials that cover complete cardiovascular surgery. This slide presents his major research and surgical fields, but as you know, he is one of the world's experts regarding repair of the aortic arch. He is a member of many German as well as international societies and associations. He is a founder and course director of this well-known international symposium, Aortic Live. Ladies and gentlemen, one could talk much more about our distinguished guest, but we are here because of him and his lecture. However, before that, allow me to invite Professor Pekmezovic, the Vice Dean of the Belgrade Medical Faculty. That is also great honor and privilege for me. Professor, please.
Thank you. Distinguished guests, dear colleagues, on behalf of Dean of Faculty of Medicine, Professor Academician Nebojša Lalić, and the Scientific Council of Faculty of Medicine, I have great pleasure and privilege to promote Professor Heinz Ginter Jakob into the title Visiting Professor of Faculty of Medicine, University of Belgrade. Our decision, based on your extraordinary scientific and clinical work and research, Professor Heinz Jakob is worldwide recognized person in field of vascular surgery. Faculty of Medicine, University of Belgrade, established 99 years ago and is a leading institution for medical education and research, not only in Serbia, but we have significant position in regional framework. This position is a result of long-term efforts of generations clinicians and researchers. Among them, a group of vascular surgeons, Serbian vascular surgeons, leading by Professor Lazar Davidovic, has special position, not only due to clinical work, but also for impressive number of top quality publications in the field. I again welcome you in Belgrade at our school, and strongly believe that established collaborations between Professor Jakob and Professor Chiesi, if I say well, and our vascular surgeons will be strong in the future. Thank you very much. Please receive our diploma.
Spectabilis, Professor Davidovic, Professor Kostic, Professor Chiesa, dear colleagues and guests, that's a great honor. I feel extremely privileged getting this visiting professorship, and I hope I will do my very best in the future to support you and our colleagues from cardiothoracic surgery in developing this field in Belgrade, as well as, for example, in my place in Germany. So this is the topic given to me by Professor Davidovic, and I know that most of you are in the field of vascular surgery, so I try to give you all the details we elaborated over the past 15 to 20 years in Essen. So I have a disclosure. I'm closely related to Jotek Cryolife because I invented a couple of prostheses, and the Evita Open is now implanted worldwide over 10,000 times. So the background of my work is complex ascending, arch and descending aorta aneurysms, for example, this patient, or and in the past with these kinds of pathologies, we have the problem that patients have to undergo at least 2 operations. And as you can see here, treatment mortality, stage 1, interval, and stage 2 is up to 36%. And many patients don't return for the second operation. So this is a major problem. And the other important field is acute type A aortic dissection, in this specific case with tamponade. So the patient is endangered to die immediately. There's a 1 to 2% mortality rate during the first 24 hours, so we are under pressure doing something. Historically, cardiac surgeons do proximal repairs. It's a fast operation, so the entry part in the ascending aorta is resected, the proximal aorta is replaced, but the distal aorta is left conservative. And as we had the experience over time, not moving forward.
We will try to restart it.
Okay.
There is a problem.
Yeah, so it's a life-saving operation, but in almost 90% of the cases, the false lumen channel stays open, and this creates problems over time. Okay, there it is. As you can see here, 1 year after surgery, this situation, persisting malperfusion, 8 years after surgery, new malperfusion syndromes, mainly abdominal malperfusion. And this man, 34 years, Marfan, even after stentings, persisting malperfusion symptoms. So, another example, 40 years, 1 year post type A repair proximal. Another patient, 10 years post type A repair. As you can see, small true lumen growing aneurysm around. So the reoperation rate probably is around 40% at 10 years. Of course, there's debate in the literature, but this also corresponds to our impressions. If we do have residual or re-entry tears in the proximal descending aorta, you see survival at 10 years is much less than 50%. Why is that so? Because we have this large tear and we have an increased wall shear stress in this area, causing aneurysmal formation and ruptures. So, for all those reasons, we have to do more. This is the aneurysmal problems. This is the post-dissection proximal repair problem. We want to, in the best case, avoid a second stage operation, or we want to reduce the risk of re-intervention downstream. So in the 21st century, we want to do a primary ascending arch and descending repair to the mid-thoracic level. And of course, many of our patients have also to undergo additional cardiac procedures. We want to have it at low risk, short periods of hypothermic arrest. Cardiopulmonary bypass time also should be short as possible. And we need to have this procedure for elective as well as emergency situations. This is the extensive repair techniques available. The classic elephant trunk, arch repair plus T-VAR, debranching, type 1, type 2 repair, or the frozen elephant trunk technique. So I started out in 2001 using the talent stent graft, and we had problems, and this prompted the development of this hybrid prosthesis, was called Evita Open by the company. It's integrated covered stent graft with a directly connected Dacron graft for the arch and distal ascending aorta. The operation is exactly the same as for the classic elephant trunk. The only difference is that we need a stiff guide wire placed in through the femoral artery. And we must be sure in the dissection patients that the guide wire is within the true lumen. So I had one experience in my early days without that, and the frozen elephant trunk landed in the false lumen with catastrophic follow-up problems. So this is very important, as well as in the sclerotic shaggy aortas we want to pass by without sharing off debris and thrombus. For the aortic arch, we have the island technique. We can also re-implant the head vessel separately. We can do transposition, or of course we have also available branched grafts. So we have now the device, but over time, as you can see, 2001, 2017, many concomitant developments took place to make this kind of surgery more reliable, more safe, and better. And I thought I'll share with you the very important things, I believe, which contributed to improvement of our results. Cannulation. There are several modes of cannulation, and the axillary artery is the favorite cannulation site. But in case of dissection, for example, we have the alternative, the left axillary artery, or the central cannulation in acute type 1 dissections. Oops. Yep. And so this is again the tough situation, and as you can see here, we have also problem with the coronary circulation. So it's difficult, and here you can see the section of the truncus brachiocephalicus. So we developed open vision aortic cannulation, and I'll show you this in my second talk with a video how to do it. So it's very fast, very reliable. Perfusion regime. As demonstrated already by Professor Chiesa, it's really important to have perfusion all over. So this is the typical setup with a heart-lung machine, venous lines, right atrial appendage. We have a vent line. Oh. And we have two pumps, the centrifugal pump, and we have the right axillary artery cannulation. When we are operating in the open arch, we also cannulate the left common carotid artery, and we have a second pump where we cannulate the left axillary artery and the through the prosthesis for the descending aorta perfusion immediately after constructing our distal anastomosis. So every regions of the body are perfused. In elective surgery, we have the LicoGuard, as already demonstrated by Professor Chiesa, to keep the pressure in this, around the spinal cord below 10 millimeters of mercury. We keep up the mean arterial pressure high, and we leave the LicoGuard in the patient for at least 72 hours. Of course, we have the brain perfusion with a pressure of 50 to 60 millimeters of mercury. We have NIRS, near-infrared spectroscopy, to watch at least the perfusion of the frontal parts of the brain. And we do 3 head vessel perfusion. We learned that from the Japanese colleagues because we want the collaterals also to via the left subclavian artery and the vertebral artery to perfuse the brain all over, as well as the spinal cord via collaterals. We don't go further down than TH8 to reduce the risk of paraplegia in all those patients. Angioscopy, very, very important development. We started out already in 2005. And in the phase of circulatory arrest with brain perfusion, it's possible to have a look inside the aorta using a specialized videoscope from Olympus. For this, we have the possibility to identify the re-entry situation in the descending aorta. And more than 40% of the patients have re-entry sites in acute type A dissection. We check the landing zone for our graft. The guide wire is not always in the true lumen. We control the unfolding of the stent graft and we evaluate the landing zone. So this is examples where the guide wire is stuck. You see here. Now with the visualization, it's easy, as well as here. You see it's stuck in the aneurysm, and this is the small true lumen. We have to bring in the evita in the true lumen, otherwise it would be a catastrophe. So this is a very important tool in our hands. And you see, we checked, it's my coworker, Dr. Tsagakis, 73% of the re-entry locations is in proximity to the offspring of the left subclavian artery. And even those down to 10 centimeters can be covered by the stent graft. In case we have a longer aneurysm, we calculated beforehand in the elective cases. We know that the stent graft has to land here, and we can control it via angioscopy. And this is the perfect location controlled later on. Okay. Fast distal perfusion. You are familiar with the Ishimura zones, and the classic elephant trunk anastomosis takes place in zone 3, but as you can see here, that's distal of the left subclavian, and there's a recurrent nerve. And that's not an easy thing to deal with, especially in emergency situations. So zone 2 is much more surgeon convenient, and this is what we have done in recent years. You see here, this is the recurrent nerve palsy rates in the French registry, 17%, Rester from Hanover, 25%, and we had 11%. It's unacceptable. And in addition, in our studies of our own risk factors, in the multivariate analysis, cardiopulmonary bypass duration is a significant risk factor. So we must become faster. And we achieve that by doing extra anatomic bypass from the left axillary through the left upper hemithorax into the mediastinum, where we can perfuse, as I demonstrated before, during circulatory arrest. And later on, we connect the 8mm graft to any portion where it's convenient. And this speeds up our operation. Cardiopulmonary bypass time, arrest time, selective anterior cerebral perfusion time, visceral ischemic time, very important, comes down significantly. So we are currently at about 30 minutes. So this enables that we don't need the very deep temperatures as in the past. So we are currently, in the usual case, cooling down to 30 degrees core temperature, and while doing the perfusion of the head vessels, we go down to 22 degrees. Sizing, we learned that we don't oversize. We just measure the length of the membrane. So this is the true lumen, that's the false lumen, and we are measuring here 30 millimeters, so we are using a 30mm graft. And look at this, chronic case, 26 millimeters, so we are conservative, using a 24mm graft. And you see over time the false lumen gets thrombosed and remodeled. So this is very, very important adjuncts in this kind of surgery. In Europe available are the Evita Open as well as the Thoraflex, and many surgeons prefer to use this graft due to its 3 branches. It might be a little bit easier to be operated. So this is the current indications. We are using the frozen elephant trunk, of course, distal arch aneurysms, proximal and descending aneurysms, chronic type A's or complex type B's, and the acute type 1 dissection. Not all patients, but as soon as there's full circular dissection of the distal arch with re-entry tears in the proximal descending, we are using this technique. So this is our results. 316 patients, 54% acute type 1s, 23% chronic type 1s or type 3s, and aneurysmal patients 23%. 55% of those patients were emergency cases. This is the results. In hospital mortality, 12%, 11% in the non-emergency versus 13% in the emergency cases. No statistical significant difference. Stroke rates, of course, it's still significant, but you must remember that there come patients in already with stroke in case of acute dissection, and we operate on those patients. Spinal cord ischemia, overall paraplegia, paraparesis, 5%. Renal replacement, temporary renal replacement comes down to 25% in the non-emergency cases. Re-exploration, 8-9%. Intubation time is longer in the emergency cases, no doubt. Cumulative survival at 5 years, 67%, at 10 years, 55%. Probably it's getting better. Overall freedom from descending aorta re-intervention at 10 years, 69%. But look at this blue line. This is the acute type 1 dissection patient. So it's at 5 years, 92% freedom from any kind of re-intervention. Of course, the chronic dissections as well as the the aneurysmal cases have to come back more often to treat the downstream pathologies. But here you see the difference now in survival. Zone 2 anastomosis, faster operation in contrast to zone 3. So this is already significant at 5 years. Now we have a survival of 73%. So it's a cumbersome development, but we have to be consequent in improving this kind of surgery. Do we reach our goal to have the false lumen disappear around the stent graft? Yes. In 96% in the acute cases and even 90% in the chronic cases. But further downstream, of course, those patients have to undergo lifelong surveillance, and we check all patients in intervals of, let's say, 1 year, and in the very stable patient, 2 or even 3 years. But all patients must be surveyed. This is the result we want to get. Very stable situation over 14 years. You see there's a little residual type B, but it's absolutely stable in most patients, so we can accept this. Another patient, 10 years follow-up, the acute situation, post-operatively prior to discharge. Here's the Evita. You see already thrombosing of the false channel further down. It's continuous perfusion. 1 year, 5 years, 10 years. You see there's calcification of the outer circumference, but it's stable. And theoretically, of course, we could treat the re-entry site in the iliac artery, but this patient is stable. Do other centers get the same results? Yes, they do. 20 centers are contributing to our EVITA Open International Registry. And now we have the data, must be published soon, of 1,165 patients. Incomplete data, only 130 patients, so they were excluded. So this is the long-term survival, 66% at 5 years, and here the same survival in acute and chronic dissection patients. Freedom from downstream intervention, a little bit less than in Essen. This is cumulative, all types of surgeries, but also here you can see the acute type 1 dissection patients are stable over time. New developments. As I mentioned, many surgeons don't like the tube graft, so the company now is is producing a branch graft. So the idea is to bring our distal suture line from zone 2 to zone 0. And for this reason, we use this Spielvogel type of trifurcated graft. So this is the prototypes you can see here, the 3 vessels, so for the truncus, for the left carotid artery, for the subclavian artery, and there's a perfusion port. And this is the first patient we did at our Aortic Life meeting in 2017, a real complex patient, 79 years old, aortic arch aneurysm. He had a stroke, he had stenting of his right carotid artery, and he had an endarterectomy of his left carotid artery, and he has a Y prosthesis in his abdominal aorta. So cross-clamp time was 62 minutes, visceral ischemic time 32 minutes. Perfect result. Another new concept, the Enovia. The idea is to have a graft for the real very, very acute case. So it's the distal covered stent, for the arch, a non-covered stent, and here the dacron prosthesis for the anastomosis in the ascending aorta, zone 0. So this is how to do it. Proximal repair, then unilateral perfusion, implanting the device, unfolding, doing the non-covered stent in the arch, and doing another anastomosis for the very acute patients, so pen class B, C, or BC, old patients, severe concomitant disease. So brief video. I show another one more in detail, but as you can see, it's very fast. And this patient had hematemesis for 8 hours, so this is the real endangered patient. And we had to operate. Usually we wait and do primary stenting of the thoracoabdominal aorta, but he ruptured in his ascending aorta, so we had to go forward. So this is the problem. Whatever you do in the arch, as you can see here in this 4D demonstration, that we have longitudinal and radial forces in the arch, and any kind of stent has a problem over time. And we had to learn that the non-covered stent tends to stretch over time in the first generation. So we modified the graft, as you can see here, bringing in the covered stent. There is a tissue bridge and a non-covered stent, you can see here. And this is the situation. Theoretically, we also can stent the carotid or the truncus through the mesh of this stent. And this is one of my last patients. Very problematic case, 69-year-old female, end-stage COPD. She was on chronic oxygen and pulmonary cachexia, and she was fainting while visiting with her pulmonologists. Hemodynamic collapse, intubated, rushed to us. That's the situation. And this is her post-op CT scan. You see perfectly open stents. All head vessels are open. Nice alignment to the distal arch and the proximal descending. Finally, I think 6 months later, she died of her pulmonary disease, but the aorta was all right. To overcome the problem of stretching, now in the last generation, a traction suture is integrated in the non-covered stent, and this is the solution, and I will show you the video later on. So this is the results. Only compassionate use patients. You see 68 years, very, very old patients. Only one patient, pen class A, all others pen B or BC. Additional Bantal, CABG, mortality in hospital, 2 patients, 18%, so late mortality, as I mentioned, the lady with the pulmonary problems. Residual stroke, 1 patient. So for this devastating patient population, not so bad. So the company will continue in developing this device. So in conclusion, Evita Open Plus, Neo, and Innovia represent a family of graft variations for all kinds of pathologies, for all situations involving the arch and the adjacent aorta. So I believe this will be the new gold standard for complex thoracic aortic disease. Here again, the pictures, the Evita Open Plus, Innovia, Neo, and here the Milano variation, Dr. Chiesa's group, here with one big branch for the head vessels, and here the perfusion part. So I think this is the future we have to go. Thank you very much for your attention. And again, my thanks to Professor Davidovic and the Dean for this honor being invited visiting professor for Belgrade.
Thank you very much, Professor Jakob. At this point, I would like to ask, do we have any question for Professor Jakob regarding this lecture? Igor?
Thank you for your marvelous presentation. One of the problems we see when we treat type B dissection with TIVAR is the destiny of the left renal, because usually left renal is going from the false lumen. So in your patients with type A dissections that you treat with the frozen elephant trunk, do you try to recanalize the left renal? Do you follow the patient? What the destiny is of this kidney? Do you have information?
Yeah, this is correct. Most patients have left renal gone. If we do have a re-entry situation with big re-entries in the thoracoabdominal part, the left renal comes back. But in other patients, we are losing the left kidney, and they are stable in regard to their kidney function. We have, theoretically, we have now the opportunity to treat the whole aorta in one go. But this is still future. But we have already 5 or 6 patients, and it's only my coworker, Dr. Tsakakis, who is able to do that. So when we have the open situation, the perfusion of the head vessels, he's able to scan the aorta down to the bifurcation, and then it's possible to plug in non-covered stents, EXL stents, from the bifurcation up to our frozen elephant trunk. And just the other week he has done such a patient with excellent results. I'm a little bit afraid of spinal cord problems. For this reason, we are still not very aggressive, but we have now the experience in 5 patients without spinal cord problems. So this might be the future, to treat type A dissection in one go and have a final result.
Thank you. Professor Chiesa?
Thank you very much, Professor Jakob, for your fantastic experience. I think that this is the best experience for the heart repair in the world, and I am very honored that it's coming from Europe. And I think that one problem is still open. The delay in the treatment of the descending aorta, and I ask you what you think that will be in the future the best way to treat the dissecting aneurysm of the descending aorta, endo with connection to the Evita or the prothesis that you choose, or still open repair. What do you think that will be the future for this type of patient? Thank you for your presentation.
Yeah, in the Marfans, no doubt, secondary thoracoabdominal replacement. As a bridge to the second stage operation, we could do stentings, but it's not stable over time. But in the redo cases we have, endovascular approaches are safe. So if the anatomy is not very complex, it's very easy to bring in stents into the distal part of the Evita. So you can get a perfect seal, overlapping maybe 5 centimeters, and we have stable results in those patients, but not in connective tissue patients.
Thank you.
Thank you very much. If we have no more questions, I would like to give congratulations to Professor Jakob. I would like to thank Professor Pekmezevich for joining us here today, and we shall go on with session 3. First of all, I would like to ask the General Secretary, Dr. Končar, to take my place. Ovo je moje, evo ti ovo.